Let's all pray. Eternal God, our Father, it's again that we come before Thee, and as we come this morning, dear God, we are so thankful. We are so grateful, God, that we are experiencing Your goodness of this day. And I pray, God, that this event will be such a success, God, that it will give us the information that we need, God, even in healthcare, that we can go forward, oh God, enjoying that life that You have given us. We thank You and we praise You for all things that You do. You do all things well. These things we ask in Jesus' name we pray. Amen.
Well, good morning. Today is all about helping men learn how to live their healthiest life. And making small changes to what they do and hopefully having big impacts. We know as men there's at least two things that we aren't good at. The one is taking care of ourselves. We'll tell someone else what they should be doing to live a healthier life, but it's difficult for us to often internalize that. The other thing is we're going to try and break down that barrier today is men are also not good about asking for directions and taking those directions. Well, we've got a lot of healthcare providers here today. They'll help men provide some direction to the men. Hopefully the men will internalize it and go back and share the word with others so that others in their social circles, those in their church, those in their family, in their neighborhood, can also learn about the changes that they can make in their lifestyle and their behavior to live a healthier life. This is about not only living a healthier life, but potentially adding years to your life. Small changes, big impacts, that's what today's about. So thank you, those that are here. Thank you, certainly all of our vendors, for being a big part of this. We certainly couldn't do it without you.
Good morning. I will not restate what Pastor Coles and Tom Kulikasa has already said, but I do want to thank all the vendors for coming up and setting up and providing the resources for us as men to go around and learn more about our health. Today, this is our third year, so I would encourage all men to really engage the vendors at the tables. I would encourage all men to really go through the screening as well. So with that, I thank you for coming.
I did forget one thing. The passports that everyone receives are the key to winning some great prizes. We have 10 pairs of tickets that will be raffling off. Everybody completes their passport to an ECU football game of their choice. And our grand prize is we have a pair of tickets in the Town Bank box for the ECU football game in the latter part of October versus Temple. And then the ECU Wellness Center has also provided us with 2 one-month passes. So there are 10 pairs of tickets, a grand prize, a pair of tickets in the Town Bank box, and then 2 passes to the ECU Wellness Center. So go forth and make sure you visit all the tables. And if you visit 7 tables, you get 1 entry. If you visit 10, you get 2. And if you visit 14, you get 3 entries. So the football theme continues. 7 points is a touchdown, 10 is a touchdown and a field goal, and obviously 14 is 2 touchdowns.
Thank you. Thank you for that introduction. And I want to thank the First Presbyterian Church for having me here today to speak to all of you, and it's my pleasure. And I also want to thank one of my nurses, Jennifer Lewis, who's in the back. She was instrumental in getting us together and asking me to speak. She's one of our 100 great nurses in the state of North Carolina. So it's great to have someone like her as a great resource to talk to and ask questions and for education purposes. So my pleasure, as I said, to be here today. As was mentioned, my name is Dr. Blute, Michael Blute, and I'm a urologist. I specifically trained in urologic oncology, so I deal on a daily basis with all urologic cancers, including prostate cancer, bladder, kidney, testicular, and penile cancer. So there's a lot going on there that we address every day from a multidisciplinary approach, and certainly a lot to do with men's health. But specifically this morning, I'm going to talk about the importance of PSA screening, prostate cancer screening, what that means for men, get you to understand a little bit more about your risk, and that's the most important thing, so you can have that discussion with your doctor, your primary care, or urologist about screening and how that can help you from a preventative measures standpoint. So I apologize, let me get this to one of the, was it Octavia? Yeah, just it's not linking up. I apologize, a little IT issue. Oh, here she is. It's not linked, the laptop. It's not linked up to the, I can't advance. Not sure how that. No. Okay, that's better. Thank you very much. I appreciate it. Okay, got that worked out. So I'll start just by describing what the prostate gland is and its role in a man's body. We're all born with one. It's part of the male reproductive system, the genitourinary system. And if you look at the picture off to the right, that would be as if you're looking at me from the side. You split me in half, and this is the male anatomy. And as you can see outlined here, the prostate is that red oval-shaped structure. It's a gland. It sits in close relationship to the bladder, so that's why it causes issues as we get older in terms of symptoms we call lower urinary tract symptoms. It becomes important from an anatomical standpoint, also for screening purposes with physical exam. But as you can see, the urine fills up in the bladder from the kidneys, and it's transported through the urethra, and that urethra passes right through that prostate gland. Okay, so that, like I said, overall for men's health purposes, very important to understand that. And this is where reproductive secretions and solutions the gland makes in order to allow us to procreate. It also takes part in allowing passage of urine. It's in close relationship to the musculature in the pelvis and sphincter that allows us our continence mechanism, or ability to hold urine in. Okay? It's also, from an anatomic space, closely related to bowel, which, as I said, plays an important role in our screening purposes, which I'll talk about in a minute. So what is prostate cancer? Well, like any other cancer that we have, such as pancreatic or lung cancer or bladder cancer, prostate cancer grows in a similar way. And basically what happens is the cells over time, as a cancer of age, begin to divide and multiply. And when they start to do that very quickly, they become cancerous. And for prostate cancer, as I said, the cells originate here. and they tend to first grow. It's, for the most part, a fairly slow-growing tumor. A lot of men in their 40s will actually have prostate cancer, and it won't manifest, show symptoms until 20, 25 years later in life. Okay, so that's another thing to note. It is a cancer of age. The older we get, the more likely we are to be diagnosed with prostate cancer. It can spread after it invades locally other tissues in the pelvis, but it can also spread elsewhere in our body. That's called metastatic disease. And specifically, most common places are bone or skeletal system. About 70% of prostate cancer, when it does metastasize, goes to bone, which can cause symptoms. However, most men in a screened population do not have symptoms at all. Most prostate cancer, when it starts out, and as I said, it will lay in the prostate cancer and rest there as what I call an indolent tumor or slow-growing tumor, and it'll be microscopic cancer. It won't cause any symptoms whatsoever. However, when it does cause symptoms, it can contribute to what we call, as I said earlier, lower urinary tract symptoms. If the tumor within the prostate gland starts to grow locally and it's no longer microscopic, it can cause obstruction where you cannot urinate. That's called urinary retention. It can cause frequency and urgency of urination. It can also cause sometimes blood in the urine. Now, when the cancer eventually spreads, if nothing's done about it over time, it will cause symptoms, specifically pain. And as I said before, 70% of cancers first go to bone. So a man who's got metastatic cancer will indeed have bone pain. It can also lead, because the tumor in the region takes over the bone and replaces it with prostate cancer, it can lead to fractures. We call those pathologic fractures. And again, it can be very painful. Okay? So, but important to note, the majority of prostate cancer is asymptomatic. Well, what are some of the facts? It is the most commonly diagnosed non-skin cancer in men in the United States, and the second leading cause of cancer deaths in men in the United States. Lifetime risk, very important. A lot of it's based on race. Majority Caucasians, but other races in the United States, about 1 in 8. But one of the main risk factors that we have is African American heritage. It's about 1 in 6 men of African American background will be diagnosed with prostate cancer in the United States. Incidence increases with age as we get older. If you take all men in their 8th and 9th decade of life, about 70-75% of them will have prostate cancer. Now, at that point, the vast majority of them, if they're not symptomatic, will pass away, die with it, as opposed to of it. In this data here in 2024, this is from the NIH, or the National Institute of Health, and the National Cancer Institute in Washington, D.C. They project in this year, 2024, almost 300,000 cases of prostate cancer will be diagnosed in the country. About 35,000 deaths. Percentage-wise, it's about 6%. Percentage, that's not that high, but 35,000 deaths in the United States from a cancer in a population is, pretty significant. So important to note, in a screened population, about 20% of prostate cancers are indeed clinically significant, meaning they can harm a man and they can lead to his demise eventually. As I said, the microscopic cancer, men in their 40s and 50s, almost 35%. If you biopsy everybody in the United States, will have prostate cancer. And as I said, about 75-80% of men in their 90s will have prostate cancer if they get to that point. But like I said, microscopic cancer does not always mean it is a lethal cancer. We have a spectrum of prostate cancer that's diagnosed. We group those men into risk, low, intermediate, or high risk. And that risk is based on metastases and death from prostate cancer. So what are effects? This is, I think, a very important slide. I think the top 3 are the most important. These are really risk factors that are causes of prostate cancer specifically, or significantly related. The bottom ones, when it comes to diet or obesity, chronic inflammation infections, are mainly associated, not necessarily causal. But in our research that we've done, these risk factors, significant amount of men who are obese will have more likely to be associated with having prostate cancer compared to those who are not. But as I said, age, very important. The risk increases with age as we get older. Race, know your risk, very important. If you're African American, to know your risk in terms of from a racial background. That is one of the most important risk factors when a man walks into a urologist's office for determining if the man should undergo prostate cancer screening with PSA testing and physical exam, and ultimately if they're going to need a biopsy. The second most important is genetics or family history. Prostate cancer, like all other cancers, undergoes mutations, genetic mutations, and that's how it arises and how it starts to grow. If you have family history, a positive family history, that's very important for a primary care physician or a urologist to know that risk factor, particularly first-degree relatives, such as a brother or your father. Had prostate cancer, increased levels of risk for harboring prostate cancer in the gland. So what about the importance of screening? And I'll go into that. But the importance of it really is it educates the patient for early detection of cancer. The earlier you catch it, the better off you are with getting past it and getting it treated. And the effectiveness of the treatments that we have for prostate cancer. The earlier you have it diagnosed, if you have it, the better off you are. So there's more options for you for definitive therapy as opposed to treating it when it's at the metastatic state. There's really no cure for prostate cancer once it gets to that point. But important to know with that any disease that's low risk, that's organ confined, most men, once it's definitively treated through something like surgery or radiation therapy, 15 years later, most of them, almost 100%, are still alive. So what is prostate cancer or prostate cancer screening? Well, it's two things really at its most basic form as outlined in this slide. First is with a blood test, PSA blood testing. Now what's PSA? PSA stands for prostate specific antigen. Basically what it is, it's a protein that our prostate gland produces in low volumes and it will circulate in our blood. In higher volumes, it is increased with disease entities that are related to cancer but non-cancer issues as well. So men who have what's called BPH or an enlarged prostate, our prostates all get larger as we get older, PSA can go up. Infection and inflammation can cause the PSA to go up. And certainly age. So I mean, if you check a PSA in a man who's 85, it's going to be much higher than a man who's 40 or 45. So that's another thing to note about the screening. PSA, the blood test, is not disease specific. It's organ or gland specific. So just because you have an elevated PSA does not necessarily mean that you have prostate cancer. But it is our most effective baseline screening tool that we have. It's an easy, quick blood test. And then the second portion of prostate cancer screening, as outlined here in the picture, is the physical exam portion with a DRE, which stands for digital rectal exam. Your physician will don a glove with lubricant on their finger and they will place it in the rectum as it shows in the picture here and feel the prostate gland. As you can see anatomically, the prostate sits right in front of the anterior wall of the rectum. And indeed, most prostate cancers, about 70%, when they start to show up on an exam, will show up in the posterior peripheral aspect of the gland. So we can actually feel the cancer. It's a lump or a bump, and it's hard, usually painless. If either that, certainly if you feel that on the exam, or if there's a worry about the PSA being elevated, that will prompt a recommendation for a biopsy, and it should from a urologic perspective. So if there's any issue, if you're being screened by your primary care physician, with either of those tests, referral to a urologist for a prostate biopsy should be made in a discussion with the urologist. So who should be screened and when? A little bit of controversy behind PSA screening, specifically occurred about 10 years ago with regards to if we should even be doing it. The reason why, because PSA is not, as I said, disease specific. Just because it's elevated doesn't mean a man has prostate cancer. But the recommendations generally are by our American Urologic Association, our governing body in my field, as well as the NCCN, the National Comprehensive Cancer Network, for all men to begin PSA screening or have a healthy discussion with your primary care physician or urologist about, number one, your risk, and if you should undergo PSA screening for prostate cancer. Really, I apologize, it really should be about 50 to 69. That's the age group for the general population. And certainly anybody who is at risk, and the two main risks is positive family history and African American background should really start in the 40s. Some would say at 40 to get a baseline PSA, but at least at the age of 45. And PSA screening is done annually. It's done annually with the blood test and the digital rectal exam. If those are normal, all within normal limits, it's usually on an annual basis. Our American Urologic Association would recommend every other year in low-risk men. I think most urologists in my field, particularly if there's any concern, that you would do it on a year-to-year basis to pick something up. What is a normal or abnormal PSA value? Again, this is very important. As you can see here, the main thing is to look at the age, the number, and the number of the PSA lab value. Overall, 4 is the threshold. So anything above 4 would be abnormal. Anything below 4 would be within normal limits. However, again, it has to do with age. So if you check a PSA in a 49-year-old gentleman and it's 3.5, as a urologist, even though that's within normal limits, that concerns me, and I'd probably recommend a biopsy, particularly if there's a positive family history. Because a man at the age of 49, PSA should be really below 2.5 or at the highest 2. Now, a man who is 65 or 70, PSA of 4, 3.5 to 4 may be normal. If you check it, and the recommendations are to sort of stop at the age of 69, but if a gentleman's got a good 10-year survival, 15-year survival, we will even continue that well into their 70s. If you check it in a 72 to 75-year-old man, a 4.2 level is age appropriate. That may not necessarily generate a recommendation for a biopsy. So important to understand these numbers in terms of your risk and what they mean. I'd like to show this slide. This was a study that was published in a high impact factor journal in the field of medicine, in the New England Journal of Medicine in 2015. Basically what it is it shows the impact of 2 screening tools for prostate cancer and then how it relates to breast cancer. Down here is time. When prostate cancer screening was initiated, roughly around 1990. And this is the incidence of diagnosis of prostate cancer and breast cancer per 100,000 population. But as you can see, the impact of what PSA screening did widespread in the United States. It dropped the incidence of prostate cancer from the 90s to 2010 significantly. Now, you compare that to mammography for breast cancer, when it was started in the 80s, it's static. So that is the importance of the impact of what PSA screening does for men in prostate cancer. Now, if you do have either an abnormal digital rectal exam or an elevated PSA, and you get a biopsy, biopsy is done in one of 2 ways. The most common historically has been a transrectal ultrasound guided biopsy. The ultrasound probe is placed where we feel the gland, as I showed you with the digital rectal exam, and we visualize the prostate gland through the ultrasound pictures, and the biopsy needle goes through the anterior wall of the rectum and into the prostate and out. That's how we get tissue. More recently, in the past, I would say 5 or 6 years, gaining a little bit more popularity, is something called the transperineal biopsy, again done with an ultrasound probe. But there's an area between the scrotum in the male anatomy and the anus, which is where the prostate sits. And so that modality basically takes away the risk of infection, which you can get through a transrectal ultrasound-guided prostate biopsy because you're going through the rectum, which is a dirty area, into the prostate, which is sterile. If you do it outside in the skin, the infectious rate is almost 0. So that's gaining more popularity, and I think that we're going to see more and more of that because a prostate biopsy, if you get really a bad infection, it can require hospitalization and antibiotics. You can get very severely sick. So that's how we find out if a man has prostate cancer. If we are able to show through imaging and the biopsy that it's localized to the prostate, we have 3 main options for a man, as long as it's not metastatic. Definitive options, well, first of all, you have that discussion with your urologist, but you should also see, and I think it's the duty of my field to recommend you see other subspecialists in radiation oncology, specifically, and medical oncology, because they also treat localized prostate cancer. So definitive treatment options are number 1, surgery to remove the prostate gland, or radiation therapy where it's done with an external beam. The machine shoots external beam radiation into the pelvis, to the prostate, to kill the cancer cells. Or you can have seeds, radioactive seeds that are placed in the prostate gland to kill the cancer cells. Sometimes we give hormonal therapy. The fuel for prostate cancer is testosterone, our own body's production of testosterone. And so those hormones that we will give patients in conjunction with radiotherapy will drop the testosterone to castrate levels to retard and prevent the growth of the cancer. Now, those are for more aggressive forms of cancer. As I said, cancers that are in those intermediate to high-risk groups. That's based on what the cancer cells look like under the microscope. For low risk, in the United States, in the screened population, about 60 to 70, 75% of men will fall under this low-risk category. You can still do surgery or radiation therapy, but another option is something called active surveillance, which gained popularity, I would say, now about 15 years ago. We've been doing this very often with men, and it is not what we call definitive treatment, and it's monitoring. And in most active surveillance protocols, after diagnosis with prostate cancer, the male will go through every 3-month blood testing with PSA. And usually at a year, if nothing changes on the PSA, you'll get a repeat biopsy to make sure there's no more higher volume of cancer or more aggressive forms of cancer. If during that the active surveillance protocol, the PSA jumps up for whatever reason, there's no other reason for it to jump up, that will generate a repeat biopsy immediately. And certainly anything abnormal on a digital rectal exam. So that is a very important option for men who have very low risk to low risk prostate cancer, low volume prostate cancer that may never harm them. Because some of the side effects from definitive treatment with surgery or radiation, significant impact on lifestyle and can be lifelong. Now, other treatments, now this is if it becomes what I mentioned before, metastatic. If the prostate cancer has left the prostate gland, gone to other parts of the body like bone. Treatment is usually in the form of systemic therapy. As I mentioned before, we will oftentimes give hormone therapy to bring that testosterone level down to undetectable or castrate levels, because that's the fuel for prostate cancer. We can also give chemotherapy, immunotherapy, use our own immune systems to attack the cancer cells, and then also sometimes radiation therapy for palliative reasons. If they have, like I mentioned before, bone pain, you can radiate the bone, relief of that pain, and then supportive measures for bone health. With reducing the levels of testosterone, men will be then at higher risk of osteoporosis. So it's important for dietary recommendations with calcium and vitamin C supplementation. We also have medications that we'll oftentimes put men on to prevent osteoporosis and bone loss. So in conclusion, prostate cancer is highly prevalent in the United States of America. Very important to identify the high-risk groups. Those men will need upfront active treatment if it's localized prostate cancer, and certainly if it's metastatic. This is a screening and preventive medicine event, so it's important to know what the importance of preventive medicine is, what that can offer you in your lives, and ultimately what your risk is. Having that knowledge is very important to extend your life and to promote a healthy living as we get older. And that really rests in having that discussion with your primary care physician. Very important. It's okay to have that discussion, and if there's any reason to be referred to a urologist, or a specialist, another important resource to have. And again, if prostate cancer is diagnosed, we have many treatment options. If it's localized, very important to have those discussions with the surgeon, the radiation oncologist, and the medical oncologist, because a lot of the men who are treated in the low risk to intermediate risk, radiation therapy, the survival with radiation and or surgery is almost neck and neck. So one over the other is not necessarily, in terms of survival, better, but you need to know the risks involved with those treatment options, the lifestyle changes that do occur after treatment, and what you are more comfortable with. Ultimately, having that healthy discussion with your physician, so hopefully you'll have the best outcomes and expectations on the other side of treatment. So hopefully I kept it simple for everybody to understand, and you got something out of this from an educational standpoint. And again, thank you for having me, and if you have any questions, I'll be happy to answer.
So I'm hoping this will be a little bit more interactive. So if any questions come up, please stop, please ask some questions and let me know. But we're going to talk a little bit about the new ECU Health Lifestyle Medicine. I'll tell you a little bit about what lifestyle medicine is, because if you've never heard of it, you're in the majority. I had never heard of it until about 9 years ago when I went to my first lifestyle medicine conference at Harvard and realized that this is something that I want to put in my career in the future. Then I'll talk a little bit about what I've seen over the course of the last 30 years that I've been in this healthcare system in Eastern North Carolina. You may realize that I've got a Buckeye jersey on. I'm originally from Ohio, but came down here and did my residency, married a local girl, and fell in love with the people in the area of Eastern North Carolina, and so I've been here ever since. I mentioned we're going to do a little bit of interactive. If everybody on this side would stand up for me, please. Six out of 10 people, adults in the United States, have a chronic disease. 4 out of 10 have at least 2. And so if this was the adults in the United States, this many people in this room on average would have a chronic disease. You can go ahead and sit down for me. The healthcare system was originally set up many years ago to deal with sickness and injuries. And we're in the process of becoming more of a healthcare system than a sick care system. And that's sort of the transition that I've seen, not only here in the East, but also during my career. So I'm going to tell you a little bit about what the mission of a healthcare system is and how that related to my experience. Then I'll tell you a little bit about lifestyle medicine, and then how I ended up from a career standpoint to be blessed to be in the place that I am now practicing lifestyle medicine. My background is actually internal medicine. The mission, and hopefully you've seen this mission of ECU Health, because it should be, people should be aware of what our truly mission is. And we actually redid this a couple years ago, but it's similar to what our missions were before, but to improve the health and well-being of Eastern North Carolina. Our vision is to become the national model for rural health and wellness by creating a premier, trusted healthcare delivery and education system. It's interesting, I told you that most healthcare systems would feel like they're still trying to move from a sick care system to a healthcare system. And nowhere in our vision and our mission does it say to prescribe the most medication or perform the best surgery. Those are certainly part of, but how do we focus on health, making people healthier? And it's interesting because I looked at the mission vision statements of the most prominent healthcare systems across the country. Every healthcare system in North Carolina has promoting health or improving health in their vision statement. Harvard, Mayo Clinic, Johns Hopkins, recognizable names in the healthcare industry, all have health as part of their vision or part of their mission. And I think every single one of them would say that we're still in the transition of moving from a sick care system to truly a healthcare system. I mentioned I went to a conference about 8 years ago at Harvard, exploring new things with career, and it was particularly around lifestyle medicine. That was the first time that I had been introduced to lifestyle medicine. And the thing that appealed to me was that it was evidence-based and scientific. So obviously that is a bare minimum for me. Having been in the medical industry, we rely on scientific evidence and evidence-based medicine and surgery, as Dr. Bluter alluded to in the previous hour. But it was not, and I had thought of the principles of lifestyle medicine more of a prevention perspective. But when I heard that the treatment of chronic diseases that are much more prevalent now, and even the reversible of chronic disease, it was important for me to figure out how I can incorporate and practice more along lifestyle medicine. Lifestyle medicine is the fastest growing specialty in the United States over the last several years, and I think it'll become obvious as to why. There's 6 pillars to lifestyle medicine. I don't think anybody will be surprised about these 6 pillars. I'm going to talk a little bit about them, but what I really want to do is get some interaction. I want to get you thinking about what, like Tom mentioned, what are some of the things that you can do to start to focus on your health and improve your health, and not wait till a chronic disease is there, or not wait till you're sick in order to be thinking about health. But the first one is nutrition. From a scientific standpoint, we know that the more fiber and plants that we eat in our diet, the healthier it is. If you saw Dr. Blut's prevention of prostate cancer, one of the things that was on there was that increased red meat and processed meats increase the risk of prostate cancer. And so we know that some of the healthiest diets are those where we incorporate more plants into our diet. Now, some people go all the way. Some people eat on a whole food plant-based diet, and that probably reduces their risk optimally. I don't think that that's probably where most of us will end up, in my experience. But anything that we can move on that spectrum where we start to eat healthier, the better we feel, and the risk, our future risk, is diminished. The second one is sleep. And I was hoping that this is a little bit smaller, so I'm going to read off of these more than I usually do. But with sleep, inadequate or poor quality sleep not only affects depression, increases the risk of depression, it lowers daytime caloric burn, which increases to weight gain, increases risk for diabetes and overall performance. So sleep is a very important perspective, making sure that you not only get enough sleep, but also that you get high quality sleep. Exercise, we all know that exercising is an important part of our health. The CDC recommends that we get at least 150 minutes of moderate exercise per week. We also have found recently that resistance training or weight training is very important, particularly when it comes to reducing the risk of diabetes or reducing the underlying issue with diabetes, which is insulin resistance. It's well documented that substance use or substance abuse, whether that's smoking, excessive alcohol, or other drugs, are an important part of overall health, and obviously one of the important parts of pillars when it exists. Some of the things that I learned too that really wasn't taught to me in medical school is the importance of stress and stress management. And I think that in the last 30 years, I feel like this world has gotten more stressful. Things are tougher, and everybody is going through some stress. So it's not a matter of preventing stress, but it's a matter of how do we manage the stress that our body's under, so that we can live our best. And the other thing that was really interesting to me is what we call social connectedness, or healthy relationships. One of the things that we look at across healthcare systems is what's a good predictor of people ending up back in the hospital. If we're taking care of someone in the hospital and we release them, we think it's important that they don't end up having to come back in the hospital in the next 30 days. And so we looked at a lot of different things. We looked at medications, we looked at coming back to follow-up appointments, and you know what the biggest predictor of someone ending up back in the hospital is? It's one simple word. Stress. Loneliness.
No relationships.
Loneliness. Wow. If we send someone out of the hospital to an empty home with no social support, that's one of the biggest risk factors for them ending up back in the hospital. Now, I've got this little picture that I like to use with my patients, and my daughter my sister who's an artist helped me put the automation in here. But if I ask somebody, if this is your kitchen and you walked into it, I've never had anybody say that the first thing that they wouldn't do, but the first thing they would do would be to turn off the faucet. Of course, I mean, we're trained that way as humans to look for a cure or look for a reversal. That doesn't mean that we wouldn't have to clean up the floor. But our first step would be thinking about, is there a way to reverse or cure this problem? Now, the next thing is going to see, this is the way I felt when I was practicing typical medicine. So think about a mop as another medication, a mop as another surgery, and that's the way we're trained. In fact, until I went to this first lifestyle medicine conference, I really felt like I didn't know how to turn down the faucet or turn off the faucet. And so that's the concept that I want to talk to you a little bit about. Now, I graduated medical school in 1994, and it's hard to see from back there, but this is a map of the United States, and on the left is a representation of the United States in 1994 when I graduated from medical school. The top is the prevalence of diabetes, or prevalence of obesity. The bottom is the prevalence of diabetes. The darker the states get, the higher the prevalence of diabetes and obesity are. When I graduated medical school, there was not a state in the entire United States that had an obesity rate greater than 25%. Now there is in the state with an obesity rate less than 25%. Diabetes, you've seen the same thing. Over the course of my career, I've seen obesity and diabetes, which we know are big indicators of prostate cancer for one, other cancers, cardiovascular disease, stroke, and diabetes. Now it's interesting, you see as we move over to 2015, the color of the United States on this graph has gotten darker and darker. I pulled the latest one, I think this was 2022, and it looks like it got lighter. But let me tell you that the yellow on this graph represents the darkest red on the previous one. They had to change the scale. It's still getting worse. Now, when I graduated residency here in Greenville from the Brody School of Medicine, we were prescribing about 2.5 billion prescriptions across the United States for men, women, and children. 2.5 billion prescriptions a year. This shows 2016, now that's almost 5 billion prescriptions. Now, we saw that we were getting less healthy over this time period. We saw that diabetes was increasing, and yet we're prescribing 85% more medications than we did before. We also see this occurring in our adolescents and younger adults. When I graduated medical school, we called it adult onset diabetes for a reason. We didn't see diabetes in adolescents. In the last 30 years, we now see a much higher rate of diabetes in our teenagers. So something is changing. Our genetics haven't changed over the last 30 years. Who we are and our genetics have not changed, so something is changing. And there's a lot of speculation on what that is, but a lot of it has to do with those 6 pillars that you and I talked about before. I came across this, recently, and this is a representation of a graph that looks at lifespan. Now, over the same 30 years, we're actually living about the same length of time. It is predicted that the next generation may be the first generation that actually has a shorter lifespan in the United States than the previous generation. But over that time, we're living about the same. But this graph shows what we call the health span lifespan gap, and that's getting bigger. So lifespan, think of lifespan as how long do we live? Health span is of that time, how long do we live disease-free? And so that health span, lifespan gap between the first medication, the first chronic disease, and the end of our life is getting shorter. It's coming earlier. It's coming earlier. I was giving this talk to a group of men actually earlier this week, and we were talking about what this meant to them. And I said this was interactive. Anybody have any thoughts or comments about this health span, lifespan gap? Do you think that you've seen it in family or community or that yes, Tom?
How much of that can be attributed to we have a more sedentary lifestyle than those that receive us, right? Almost everybody can work at some manual labor now. A lot of people are sitting in one place for the balance of their work.
Yeah, absolutely. And we see, if you looked over the last 10 years, every year when they monitor what percentage of people in the United States get the recommended amount of exercise, it's decreasing, it's going down. And particularly when you look at men's health as well. And so when we were having this discussion, one thing I would say is the thing that's causing this health span gap to get bigger, for us to get sicker earlier and have less time in, let's say, our fourth quarter, are preventable. I mean, if we look at the leading causes of morbidity and mortality in men, heart disease, cancer, accidents, lung disease, stroke, diabetes, Alzheimer's disease, chronic liver disease, suicide, and kidney disease, these are preventable diseases. There's some things that we can do in order to prevent them. And oftentimes when these diseases are early on or first detected, can be reversible. I can remember when I went to that first conference in Boston, and they were talking about reversing diabetes. I'm like, I've never told a diabetic that one of the things that we should try to do is get you off of medications. In fact, I told them, look, come back in 3 months, we'll see how the medicines that you're taking right now are working, and if we need to, we'll increase or add another one in 3 months. The thought of reversing a chronic disease actually wasn't even in my vocabulary. And it made me think of this video that I saw in a presentation a few years ago. So I'm gonna play a little clip of a video that I think, after discussing with one of the men a couple days ago, it brought to mind this video and this representation. Can you make it full screen? Can anybody hear that?
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide.
And so in my practice, when I was seeing patients every day, I was really taking care of people on the right side. What does that video, what kind of thoughts does that video spark? What kind of ideas do you have? Yes, sir.
Well, this is a fact. Since I got involved with code, and we do some kind of testing out there every month. So, since I've been doing this, my medical doctor said, what are you doing? My charts have really improved. And as a pastor, I get reports from my members that their charts have improved. So, being healthy and exercise really works.
Another thought comes to mind too. When you showed the graph around, you've almost gone from 2 million prescriptions to 4 million. A lot of times when we focus on health on prescriptions, it kind of leads people to not be healthy because now you're relying on medication to take care of instead of focus on the health and stuff.
Exactly.
There is, and I agree with everything that everybody said, I believe that there is not enough awareness. Most people are not thinking about that. Now, I'm 68 and I have seen that in my life. You know, my mom, my husband, and then people that I meet, they're only thinking about like right now. What do I want now? They don't think about that unless you have people that go through that.
one of the things that really led me to find a different career path, and one of the things, they didn't call it burnout back then, but after 15 years of practicing primary care medicine, I felt like all I'm doing is prescribing medicine. And I'm not making people get healthier, I'm helping people get more medicated. And to that exact thing, the awareness, which is, why I'm here this morning, because as I've learned over the course of my career, we need more of healthcare. Now, we still need sick care, because even with the best, some of us are going to get, it'd be less, but some of us are going to get sick. And we've got one of the greatest sick care systems in the entire world. If you're sick or if you're severely ill, this is the healthcare system you want to be in, there's no doubt. But I think we can do better when we're talking about awareness with health. Now, as part of the preparation for this, I'm involved with the American College of Lifestyle Medicine at the national level, and we have a group that focuses on men's health. And so I reached out to a couple of the national experts last week, one of which founded the first men's health curriculum in medical schools across the nation in Denver, to learn more about, because my focus has been on lifestyle medicine, but not specifically to men's health. And what I've actually learned over the last several weeks in prepping for this talk is that there's really an opportunity. So here's this is called the State of American Men in 2024, and I didn't want to read each one of them, but let me read a couple of them because I know they're difficult to see. But 30% of men don't hang out with anyone outside of their house. 1 in 6 young men have no social activities. There's a decrease in men in the labor force. So less men are actually engaging in active employment. Men are increasingly not enrolling in or graduating from college. That's an 18% lower over the last several decades. 2/3 of young men under 45 feel like no one knows them. They don't feel seen or heard. Social isolation is more of an issue for young men. Nearly half of men say their online lives are more engaging and rewarding than their offline lives. Wow. Nearly half of men say, so males consume more gaming, virtual world occupies more of their daily life, and obviously that causes a reduction in their offline relationships. And fewer boys are engaging in sports or exercise activity. One of the things that we mentioned. So if you think about those pillars, I want you to, in the back of your mind, think about those pillars of lifestyle medicine, because in a very short time that I was spending with patients, I was really focused on how high is your blood pressure? Do we need to increase your blood pressure medicine? Where's your blood sugars, your diabetes? And didn't feel like I had time or even understood how important social connectedness and relationships were, particularly in men's health. Now, if we look at the state of American men's health, men's life expectancy is 6 years less than women. Men are 4 times more likely to die of suicide. 42% of men over 20 are obese. Over 50% of men over 20 have hypertension and are taking blood pressure medications. 50% of men over 20. Now, if I asked the older gentlemen like me, how many of you were on a blood pressure medication when you were 20, 25, or 30? I mean, 20 years ago, it wasn't. Remember, something's happening. Our genes haven't changed. 30% of men get less than 6 hours of sleep per night. And from 1999 to 2016, interesting, they tested testosterone levels in adolescent and young men, and over that time period, testosterone levels were actually going down. Over 90% of men struggle with body dysfaction and negative self-affect. But I don't think we talk about that much. So I mentioned that I wanted to get this a little bit of interaction. So I want to ask you some questions. And I would love your comments or thoughts.
This is aimed a little bit at the pastors here. You mentioned social connectedness. And I know in mainline churches, style churches, we've seen a decrease in the number of men and young men going to church. Do you think, as a pastor, do you think there's a correlation between that social connectedness, which the church is
I would say it forms part of the health, but also the set of children we have today is so much different than 20 or 30 years ago. You know, what they deal with is different what we dealt with, and what we had to deal with is different what our parents had to deal with. So where you have them, if they're not going into the churches, it's not dealing with the health component, it's dealing on their mindset and their mindset at today. But it's key to keep health inside the church, because truthfully, mothers and the reason I invited a woman to this program is because some of the men won't come without the wife dragging out the problem, right? And I will say this, and I'll pass the mic on. I was at borderline diabetic myself, and it was my wife to make sure that we ate the right food. None of it was cooking unless she didn't see me. You know what I'm saying? So I just keep you in prayer. You know what I'm saying? But it was something to talk about walnuts that is good for the brains, and what was she talking about? You know, it was walnuts and yogurt and things to eat, and that was where my blood pressure went down, and she kept me on the walking. Don't give up on the walk. You know, the time I just went her up. She said, "Up, the schedule's there. Go for your walk." And so it's going to take the females, and it's going to take the church to continue incorporating these health inside the church and getting the young ones, as you said, Tom, is that their mindset is so much different. I mean, you know, that was a time that, you know, you took the TV from us. It was a problem. Take the phone from them. That's the punishment, not the TV. It's a different era. Maybe I'm not going back over there.
I think he posed a good question on why men don't attend church as a woman. So at our church, and to target that, we have we got a men's group, and we might just invite the men out and bring them together and just talk about things that interest me. Well, I'm having a vision. I can get a large group and say, hey, we're going to Virginia, we're going on a fishing trip. And they really get involved. So I think that as a pastor, we really got to target, come up with a strategy on how to get men to get involved with the church.
After COVID, a lot of things have changed. Church membership went down because people were afraid to go out. We've kept our church open regardless of what the governor said, because I know that that's a place for people to interact, is the church. But a lot of problems will come when people see that, well, we got Zoom and everything else. We made it easy for them. Just like I don't have to go to Buffalo to see the Bills. I want to see the Bills turn on the TV. And I could also turn to any ministry that's not, you know, something that I totally believe in to get church. But we got to make it back to being interesting, assemble among ourselves to get the men back. But right now, you know, I can give me some popcorn and sit there and let the television tell me something. Instead of driving and burning gas. But it's better to assemble, because then you can see if your brother's not doing so well. You know, instead of just hearing it over the phone, hey, I'm okay, and then you see that you got tubes and everything connected to it. So we just got to be reconnected to the people again. Very important.
If I may, I think a lot of these decisions, men attending the church is more related to mental health.
Yeah, and unfortunately, I think a lot of men are finding their information, or finding those connections online, and not through true relationships, but through what I'll call false relationships. So I didn't have this as part of it, but has anybody ever heard of the Blue Zones? And I'm gonna recommend some videos that if you're interested to watch, but one of them's the Blue Zones. And the Blue Zones, and in fact, ECU Health has been engaged with the Blue Zone Project in order to make the food in our cafeteria healthier, to make the food we feed our team members healthier, and what a concept to make the healthiest food available to the people in the hospital. But the National Geographic paid this journalist, his name's Dan Buettner, to go find the Fountain of Youth. And he found 5 communities around the world, 4 of which were under the poverty line, all around the world. Greece, Italy, Japan, Costa Rica, and there's one in the United States. And it's interesting, when he went in and studied those communities, and the reason he found those communities was the men and the women in those communities lived to be 100 at a higher rate than anywhere else. And believe it or not, their health span and their lifespan was very normal, was very small. So even at 90, 95 years old, they were very active in their communities, very active socially. And one of the things that they found, it aligns with all the pillars of lifestyle medicine, but it won't surprise you that each of those communities had a strong basis in faith, regardless of what that faith was, because it was different. But the sense of community, the sense of purpose was extremely important with health. In fact, sometimes when we talk about the stress and the social connectedness, we realize that we have to focus on that pillar before we even start to talk about eating healthier or exercising. It's very important. How do you prioritize your health in your daily life? We've talked about simple things that we can do. And so one of the things I want you to walk out of here with, and I've got some handouts that I want to make sure everybody gets one, is what are some simple steps that you can take towards that journey of health? Anybody have some good ideas of how they prioritize their health on a daily basis, or do you? It's easy to say, I don't.
I try to get up and walk in the morning. That'd be the first thing I do in the morning after praying.
Yeah, simple exercise, yes.
I do meditation in the morning, right after I pray, like 15 minutes, and then I stop.
Did you know that some of the studies, scientific studies out of Harvard, out of the Institute of Lifestyle Medicine, looked at 10 to 15 minutes of meditation and prayer and its impact on high blood pressure? And 10 to 15 minutes of meditation and prayer per day lowered systolic blood pressure as much as the first medication we put people on for high blood pressure.
Correct, because I take my blood pressure in the morning, and part of the reason why I started was because I did have high blood pressure, and he has been taking me off medication, because I've been meditating and all the exercise that I told myself to do. 15 to 20 minutes, if you can't do 30 minutes, then try to do at least 20, 25 minutes, but the meditation actually does help. It's a mind thing, you have to really take away all the noise and just do it, but it works.
Another thing, so she said, if we go to work, called, educational cancer, hospital cancer, or whenever it's got cancer, okay, there. Hey, so, I'm down. Yeah, what for that, and she hear that, and what the thing to resolve, I had to go in, like she talked about meditation, prayer person. We said prayer person, but I had to go in and meditate with that thing. In order for it to be better, so we don't get meditation work.
You know, I think that men have common health challenges that are unique to men. You know, obviously, what's the role of diet and exercise play in your health routine? Sometimes people, you ask me, Dave, what is the healthiest diet? I mean, scientifically, what is the healthiest diet? And scientifically, I tell you, it's a whole food plant-based diet. That means that's a diet that is predominantly fresh fruits and vegetables, close to the way they're grown. but I don't know that that's realistic for most people. And that's what I want to emphasize is, and I say this too because people ask me, well, is this food bad for you? And I say, well, it's compared to what you're eating instead of something else. You know, and so anything that you can move on that spectrum, and we always say that we meet people where they're at and try to, you know, to help them move towards health. It's not a big jump for 95+% of the people.
That's also why I'm not studying the program. Everything else, because that's, you know, my driving nature is working over that.
Yeah. Well, this is a pitch. So I remember when I was practicing primary care, I said, I remember praying if my doctor's office could look more like a fitness center than a hospital, I'd be onto something. Our clinic, if you open up the waiting room, it opens right up into the fitness center. Wow. And not only that, but ECU Health invested in not only the lifestyle medicine clinic, but right in the middle of the lifestyle medicine clinic, things that I hadn't asked for in my prayers, it was a full teaching kitchen. Because I think you're absolutely right. And I can tell you from experience that healthy food can taste good. But we're not used to making healthy food. Now, I'm going to call her out because Dr. Houston, one of the blessings of the clinic is that Dr. Houston is one of the providers. She's a doctor and nurse practitioner, has so much experience in diabetes, but even she's also a trained chef. And so we have free cooking sessions called Dinner with the Doc or Dining with the Doc, where if you're lucky enough, Dr. Houston will be the chef that will help prepare that, because I think you're absolutely right. And we need to make it not only taste good, but we need to make it easily accessible. Because even if you want to go out to eat right now, it's hard to find something that's truly healthy.
You know that cheap food is cheap.
Yeah. Yeah. And I think, and I think if you looked at over the last 30 years, the graph that I told you, I think a lot of the fast food industry has to do with that.
Yes.
And processed foods, highly processed foods.
Yes.
I'm going to kind of go through, because I know we're getting close, and you know, I realize that I'm standing between you and lunch. But I just want you to think about this. How often do you go for regular health checkups and screenings? Because men tend not to. What are your biggest concerns regarding men's health? What motivates you to stay healthy? How do you think societal expectations influence men's health behaviors? Here's one, and it has to do, I thought of this when I was watching the video. When you retire, how healthy have you pictured yourself being? Because what I've seen over my career is we spend our health in order to make money or in order to hopefully retire. And then we spend our retirement spending the money that we saved to try to get back our health. So just to reiterate, nutrition, sleep, exercise, avoidance of substance use, stress management, and healthy relationships. Oftentimes that's centered on a basis of faith. Very important. At the ECU Health Lifestyle Medicine Clinic, we're located in what many of you have heard of is called ViQuest, but it's the ECU Health and Wellness Center. You walk in the door of the fitness center to come into the door of our clinic, but we have nurse practitioners, we have physicians, we have registered dietitians and specialist nutritionists, we have exercise physiologists, we have lifestyle coaches, we have lifestyle nurse specialists, and we are looking for a licensed social worker because we're actually recruiting someone, so if you know someone interested. But we are a patient-centered, team-based approach. And we try to look at those pillars in each individual patient and try to get them surrounded by the team that will help them live their best life. My sister drew this. I don't know whether it looks like me or not, but this is, some of the most rewarding clinical decisions in my career have been assisting men to take control of their health and get off of medications. I've always said that one of the fondest memories I have is when I actually get to take somebody off insulin. It doesn't happen very often, and it's got to be a unique situation. But thinking about reversing or preventing diabetes. Prediabetes, it's estimated that 1 in 3 Americans have prediabetes, and most of them don't know it. Also, I'm involved with the American College of Lifestyle Medicine, what we call health equity, and I love this definition of health equity, the state in which everyone has the opportunity to attain their full health potential and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And that's part of what I would love to see the Blue Zone's involvement in Eastern North Carolina, is that we have healthier places to eat. We understand how to cook healthier food. We have places to exercise. We have places for fellowship or that social connectedness. And that's just incorporated into our community and the fabric. And this is we've talked about whole food plant-based, and whenever I talk about eating plants, in fact, I'll quote the gentleman the other day, it's like, I'm a meat and potatoes man. And I understand that, because that's the way I grew up. But I want, just for thought-provoking, if you've never seen the documentary The Game Changers, I want to show you this trailer, just kind of to get you thinking.
This shows commercials steak. That's what a man eats. Selling that idea that real man eat meat. But you gotta understand that's marketing. It's not based on reality. I've been teaching fighting techniques to government agencies for more than 15 years. Then I got injured. Unable to teach for at least 6 months. I spent more than 1,000 hours studying science on recovery and nutrition. And stumbled across a study about working gladiators. The gladiators were predominantly vegetarian. How could the original professional fighters be so powerful eating only plants? I made the switch to a plant-based diet. I walked up and I learned at 17. I wrote to American Raiders. I was like, man, I should have done this a long while ago.
When I went plant-based, I wasn't sure if I was going to survive, and I actually became like a machine.
One of the biggest misconceptions in sports nutrition is that we have to have animal protein to perform at a high level. That's just not true.
Sometimes you have to do things that your competitors aren't doing.
Today's blood, and yes, today's blood. That's it. This is going to wake a lot of people up. I was recovering better, not getting a sword. This is our best season in the last 15 years, and we had 14 guys off that base diet. So I will feel great, have more energy. Cholesterol was 277 today, 69. Now you're talking. Most guys my age can keep up with blood sugar. My blood sugar can keep up with it. It's not one set of dietary guidelines for improving your performance as an athlete. One for reversing heart disease and reversing diabetes. It's the same for all of them.
Someone asked me, how could you get as strong as an ox without eating any meat? And my answer was, have you ever seen an ox eating meat?
I just want you to think about, when we talk about, anything that you're moving towards incorporating more fruits and vegetables, more whole food, plant-based, less processed food, less meat, you're getting healthier. Even if you're like taking the serving of the meat and making it smaller and putting more fruits and vegetables on your plate, those things make a difference. This is the handout that will be out on the table. Please grab one. It kind of goes over some different ideas of each one of the pillars of lifestyle medicine. I put the phone number for our ECU Health Lifestyle Medicine Clinic. These are some documentaries that if you are interested and would like to learn more, these are some of them that I actually prescribe to my patients. One of them is Plant-Wise, and that was produced by the American College of Lifestyle Medicine in conjunction with Advent Health, and it's right on their website. You can watch it there. Forks Over Knives, the trailer you just saw, The Game Changers, the Blue Zones documentary that's available on Netflix called Live to 100, The Secrets of the Blue Zone. And in the interest of the football theme, can I get a Go Pirates in here? Go Pirates. No quarter. And in this football spirit, we're going to do the wave here. Live like your last quarter is the most important.